So before we start, I just want to acknowledge the presence of our colleagues from South Australia, from the BPD Co. So we have 3 of our colleagues who come all the way from Adelaide and participating in this conference. For those of you who might not know, South Australia have their own specialized BPD service called the BPD Co. So they are with us today, and thank you for coming all the way from South Australia. So we consider BPD Co as a sister service to Spectrum. It's my pleasure now to welcome Dr. Lukas Cheney, our Deputy Clinical Director of Spectrum. So Lukas is going to talk about the intersection of neurodiversity, which is his very pet topic, trauma and personality disorders. Lukas has training in DBT and MBT, and Lukas manages our complex care service, and he provides assessment, consultation, secondary consultations to complex care clients across the state and across the country. And he is strong on research, and he has published papers. And it is one of the original work that he did was to demonstrate that when depression co-occurs with borderline personality disorder, those depressions can be difficult to tease out and detect just with rating scales. So he's also a strong believer in a stepped care approach for treatment of people with personality disorders, and he believes that every person with borderline personality disorder should be able to access evidence-based care. Over to you, Lukas.
Okay, can everybody hear me okay? Thanks, Satya. Thanks for the introduction. So it's afternoon, and this is a topic which I'm very interested in, and I have quite a lot to say about, but I'm going to do my best to burn through this as quickly as I can. But please, I really welcome questions. Challenging questions are great too. One thing I want to say before I get started is something about the language that I'm going to use. Within neurodiversity, there's different schools of thoughts about identity first or person first language, meaning that you can describe someone, for example, as an autistic person or a person with autism. I might flip back and forth between those two definitions, but I generally tend to use the identity first language. The other thing I want to say at the outset is that some of the research I'm going to quote uses definitions of gender, which might be a little bit antiquated with the most current trends. But I'm going to stay true to that research when I'm using some of the gender terminology. So what I'm going to talk about is the intersection of personality, trauma, and neurodiversity. This is something that I've developed ideas about in reading the literature and seeing people over the last 5 years of working at Spectrum. And what I want to put to you is that you've heard a lot today about attachment and trauma in various forms interacting with symptoms of personality and personality disorder. And instead of covering what everybody else has said already, what I want to suggest is that there's actually a third domain to consider when you're thinking about what's led somebody to the situation that they're in when they're sitting in front of you. So what's neurodiversity? It's a term that was coined by a proud Australian, Judy Singer, back in 1998. She used it as part of a thesis in which she suggested that the term might be a less stigmatizing and more inclusive way of thinking about autistic people to start with. And so thinking less about the person as being just a disabled person and much more about emphasizing strengths and a lot like what Chloe was talking about. And then thinking also about areas of relative need where support services can be helpful. It covers quite a broad range of areas of functioning, which I'll go into a bit more detail about, but the last 2 points are the ones I'd want to emphasize is that it's non-pathological and it's not a diagnostic term. From that original definition of in describing autism, it's expanded quite considerably. And there's ongoing discussion about where the limits of neurodiversity are. But at the moment, this is from a Forbes article that was published just in the last couple months. talking about some of the potential diagnostic domains which you might call neurodivergent. And for me, when I look at something like this and I think about our population in Australia, it's really quite significant. Take autism, for example. So the population estimates are somewhere around 1%, give or take. And that's a huge change from when that autism was first coined back in 1911, when it was estimated to be 1 in about 5,000. Now we're saying that 1 in 100, or sometimes even more, could meet criteria for autism. That means about 500,000 people in Australia. And if you take ADHD, estimates of that as a prevalence is higher. It's more like 4 to 6%, which means that there's in excess of 1 million people in Australia that would qualify for a diagnosis of ADHD. So you take those two, combine them together, and you're talking about the combined populations of Darwin and Canberra. Since then, I think that this term neurodiversity actually could take on even more significance if you consider the latest in brain science. So this is Professor Anil Seth. He's a researcher based out of the University of Sussex in the UK. This is an image from a great TED Talk that you can find online, in which he's talking about the most current understanding about how a brain works. And the terminology he uses is that the brain is operating in a controlled hallucination. What he means when he uses that term is that the brain does not operate like a calculator. It's not just information in and then experience of consciousness out. It's much more like a weather map. So when you look at an image like this, this is basically collating a huge wealth of data. Wind patterns, air pressure, day-night variations. But then it's taking that information and it's distilling it down into information that's useful for you to make a decision about whether or not you need to take a jacket with you when you leave the house for the day. And the suggestion is that this is much closer to how the brain is working. I want to give you a couple examples just to demonstrate this. I'm going to stick within the visual perceptual field, just it's easier for us to access as a group. What you can see here, this is called the shade illusion. You might have seen it before, but basically what is happening is that the person is taking a piece of paper that's colored gray, and as it moves between an area where it's in the light and into the shade, it appears to change colors. The theory about what's happening here is that your brain is actually subconsciously picking up on the fact that the ambient light conditions are changing, and then it's altering your perception of the color of that piece of paper. Because it's anticipating that you need to have that color turned up for you to see it in the shade. Another really famous example is the dress. Now, I would imagine most people here have seen this image, but I'm going to take a risk and say, how many people here see this dress, as I do, as black and blue? You raise your hand. Okay, let's take your hands down. How many people here see this dress as white and gold? Right? So it's a really famous example. It made its way through all the daytime talk shows. It was this amazing joke. But if you think about this for a second, about what the implications are, it's really quite profound. This means that we are looking at this dress all together, and our brains are going through the same process of predicting, of altering based on ambient light conditions, but they're giving us different conclusions. And so the implication of this image is that we are adapting to our environment, but those environmental conditions, we respond to them differently. And if you ask me, that's really what the core of neurodiversity is all about, is that our experience of reality is different. I think that extends to personality, in that each of us has personality traits that we know very quickly when we talk to somebody, when we experience them over a period of time. We can tell that people are different, and that variation I would actually extend into the concept of neurodiversity. Now, why is that relevant for the work that we're doing at Spectrum and beyond? And just out of curiosity, how many people here would consider themselves a clinician? Raise your hand. So most people in here. So when I talk to you about concepts of formulation and environmental triggers, things like that, they wouldn't be a foreign concept. And so what I'd say with this figure here, the idea is that if you look out on the left at the green, the green part of the figure, what I'm trying to represent with the box is an inherited vulnerability that moves you up towards the blue box of developing BPD symptoms. And we know already that personality traits and risk of developing borderline personality disorder, the risk is about 50% heritable if you look at twin studies. And so we have a baseline variation of which genetic, what you get from your parents, accounts for your risk. And then the green arrow, the red arrow with the green buzz around it, would for me represent some sort of environmental trigger, whether that's complex trauma or it's some sort of insecure attachment experience. And that what we're trying to do when we're working clinically is to understand that, is to say, okay, what parts of what's happened in the past is things that you were born with, and what are the things that we think that have pushed you from that baseline vulnerability into this realm of developing BPD symptoms. And what we can see is that people come into it with varying levels of inherent vulnerability. And so the yellow for me is somebody who's at a low baseline risk and has some sort of trigger, but it doesn't get them to the point where they start having significant problems on a day-to-day basis. Now you could take that same yellow line and have somebody with a higher baseline risk in the orange, and that person would reach the level of symptomatology or starting to have difficulties. And I think, in my experience of seeing people with very complex presentations, is that some people have such a high baseline level of risk that even what some people might consider to be relatively minor environmental triggers can push people into that realm. And my personal opinion is that part of that is it can often be related to forms of neurodiversity. The first one I'm going to talk about is autism. So I would imagine people here are pretty familiar overall, so I'll move through this quickly, but it's a neurodevelopmental variation with difficulties primarily in 3 areas of social interaction, communication, and behavioral flexibility. The term Asperger's is not one we use anymore, primarily because Hans Asperger's was associated with the eugenics movement in Germany, but historically, it has been used to describe autistic people who do not have language delay or intellectual impairment. And the diagnosis has and continues to be defined by behavior and is reliant on current presentation and a developmental history. One of the things I was shocked to find out, because I knew already that there was a discrepancy in the rates of diagnosis across gender, in that boys are diagnosed more often than girls. The thing I found surprising when I learned about it is that if there's no cognitive impairment, that discrepancy gets bigger, in that boys are diagnosed even more often than girls if there's no intellectual impairment. And part of the theory that's out there about why that's happening is that the diagnostic tools that have been created to identify autistic people have been created primarily with the male presentation of autism, which is actually quite distinct from the female presentation. What does the female presentation look like? We see more of a desire for social engagement and a tendency to be mothered by a peer group in primary school, meaning that their peers are looking after them, but then that changing quite significantly in a way that can be quite awful with bullying that starts as social demands start to change when people get into high school. And that as part of that, trying to avoid some of that bullying, you might see that an autistic female will start to imitate others, start to do things that they think, oh, that person over there, they seem like they're fitting in, maybe I should try to do that. And that relatively strong language skills allow people to fit in and to go unnoticed by teachers and other people. The restricted interests also that classically we think of the boys who are into trains or can tell you every dinosaur in history. And then in the female presentation, that's different. They tend to be things that are considered to be more socially acceptable. But there can be an aspect of the presentation in females of perfectionism and being very determined that I think can play into some of the risk that we see if that determination starts to get wrapped up into BPD symptoms and in the risks of self-injury and suicide. there's actually a new diagnostic category called pathological demand avoidance, which I think, again, is in some ways related to that determination. And another thing to be aware of for this group is there's also a tendency for episodes of eating problems. So what are the risks? Autistic people, the literature is quite clear about this, that at a baseline, autistic people are more vulnerable to abuse and traumatic experiences. And that when they do have a traumatic experience, it may actually be more difficult to make sense or to communicate that experience to other people and to seek support. And that the perception of trauma can also vary for neurodiverse people. And so sometimes it may be difficult for a neurotypical person to relate to the experience that the neurodivergent person has had. And the literature is indicating that there are very high rates of PTSD and complex PTSD in autistic people. And that can translate to a 7 times higher risk of suicide at a baseline. So that's not in people that have BPD as well. This is just at a baseline, there's a much higher risk of suicide. Where's the overlap? This is an area of emerging research. There's not a whole lot out there at the moment, but the existing research suggests that there's considerable overlap between BPD and autistic traits, and that autistic traits appear to occur more commonly in people that have over 5 suicide attempts. And so the authors in this particular study have suggested that autistic traits can increase the risk of suicide attempts. Part of the theory about why there might be more issues with risk of suicide is that autistic people can also have what have been termed as spiky cognitive profiles. So we'd all be familiar with IQ. It's a long-standing general indication of cognitive function. But the IQ testing has been created entirely for people that are neurotypical. But the literature is now suggesting that autistic people in particular can have cognitive profiles that vary quite significantly. So if you take a neurotypical person, if they score on a certain level on an IQ test, it's very likely that if you look at the subdomains of that test, that they'll be fairly consistent within about 7 points of their mean score. But an autistic person can vary quite significantly. I've seen some estimates of up to 50 points in some subdomains. And so that means you can get a person who has very strong language skills and can talk to you as anybody else would, but there can be other areas underneath where things are quite difficult and that you wouldn't be able to tell unless you looked for it specifically. The common areas of difficulty are in mentalizing, which I'm going to talk a bit more about, impulse control, and communication. And to me, those things, you take those areas of difficulty and you connect them to complex PTSD and BPD, and sometimes I think it would be hard to tell them apart. Okay, so I want to give you an example of one particular area of cognitive difficulty. Now, I'm sure this isn't a new term for most people here. Theory of mind. Certainly something you'll hear about specifically in MBT in particular. In this cartoon you can see here, I'm going to name these two people, maybe Marcel and Wanda, unless somebody else wants to give them a different name. You can see what's happening here is Wanda saying to Marcel, "What's in the box?" And Marcel says it's Smarties. And then he finds out that it's not Smarties, it's pencils. But if you go to this final box here, you can see that Wanda's asked him to close the box and say, what would this other person say is in the box? And what Marcel is doing here is he is not able to use theory of mind here, because he's not able to imagine that Jenny, the other person, would also guess first that there are Smarties inside the box. And so he's not able to put himself in the shoes of this other person and say that she's probably going to make the same mistake I just did. This is a basic developmental stage, much like walking and talking. And most people will be able to do this, to complete this task by about 4 years old. And I've got a 4-year-old, and I can tell you that in the last year, he started hiding things, which is, to me, a clear indication that he can imagine that if he wants to take his Batman to childcare that day, he needs to make sure that I don't see it, because otherwise I'm going to take it away from it. But that autistic people can struggle with this, and it doesn't necessarily mean that they wouldn't be able to do this, but as this gets more complicated, as you're moving up into the realm of social interactions, and particularly nuanced social interactions, that this basic idea of theory of mind can be a challenge. And the thing I really want to emphasize is that it's not correlated to IQ. So you could have somebody who is extremely intelligent and could still have problems in this particular area. And that's come out in a study just in April this year. So I'm going to just read this out. So there's a large gap between IQ and adaptive behaviors in real life, suggesting that estimates of IQ alone are an imprecise proxy for functional abilities when diagnosing autism spectrum disorder, particularly for those without intellectual disability. And that's a big proportion of people. Up to 60% of autistic people don't have intellectual impairment. So this is an image I've taken from a website called the Neuroclassic. I would absolutely suggest you go have a look at this. It totally changed the way that I think about autism. The way I used to think about it is based on this image, is that you either go from no autism at all the way up to being, the way they've described it, tragically autistic. But that's not actually what it looks like. It's not linear. It's spiky. And so this is an image that's meant to display, it's not about diagnosing autism, it's about understanding the various strengths and weaknesses that the person may have underneath that diagnosis, and that these things do not always go together. You can have relative strengths and weaknesses, and again, you can't know it until you check for it. And so I wanted to check. And so I chose a few that I thought would relate to some of the screening measures that we use commonly in clinical practice, and then match them up. So the first one here is called the TACIT. This is a test of social inference, which was recommended to me by a neuropsychologist. You see videos of people expressing emotions and also watching interactions between people, and then you give answers, and then it relates it to a normative sample. The other one I've used is the Montreal Cognitive Assessment. This is a general screener for cognition. And the third was a very brief self-report for symptoms of ADHD. And when you look at this, the top line is the results from the TACIT, and the bottom line is the results from the MACA and the ADHD screener. Anything in blue is an indication of a positive finding, meaning that there were issues on those screening measures. Now, I want to qualify this because this is about 30 people, and it's from the people who were referred to us for the very complex, very challenging mental health situations. And so it wouldn't be representative of the general population. But certainly that figure about ADHD led me to look into that into more detail as well. And what I found was some really interesting stats from a review that was done not long ago that specifically looked at the crossover between ADHD and BPD. And the estimates of the genetic heritability of ADHD are 70 to 80%. So it's really high. And that with that baseline genetic vulnerability again, there's also clear evidence that if you grow up in a difficult social circumstance, that you're more likely to have more severe symptoms of ADHD as well. And there's some estimates that there's a 19 times odds ratio of developing BPD if you have ADHD. Many of you may know already that NHMRC guidelines for the treatment of ADHD have just been released in the last few weeks as well. So how does it all fit together? How does ADHD, trauma, BPD, how does it all fit together? This is really young science right now. There's a lot of questions still to be answered, but again, that review commented specifically on a study that offered placebo versus stimulant treatment to people that had ADHD and BPD. And they reported that people who had treatment for ADHD did significantly better in psychotherapy courses than in the placebo group. So what does this mean for how we approach these complicated presentations? Should ADHD and autism always be screened for and considered? And should medication be considered? These are outstanding questions at the moment. Why do I think neurodiversity is important after all this? One, I think that thinking about neurodiversity, even if all you do in the end is rule it out, can be a very therapeutic process of saying to the person, why has this happened? What's going on? Is there something about you that might be different than somebody else that means that this was more difficult? And that doing that can be something that actually contributes to the therapeutic alliance if you do it in the right way. And that going through that process can help a person and their loved ones to come to terms with difficulties and challenges faced. They can finally say, okay, like everybody's been telling me, it's because they must have experienced some sort of trauma or somebody's done something wrong. But if you can turn and say, no, actually, really, you just had that very high baseline of risk, sometimes I've found that helps people to come to terms with it. And that also can lead to changes in opinions amongst healthcare workers. If you can reframe somebody's difficulties through a neurodivergent lens. And that it also means you can be more effective in intervening if you're considering all the different things that are contributing to the person that's seeking your support. So a quick word on the screening measures I'm using regularly. I don't use them every time, but when I think that there may be an indication, the ASRS is for ADHD, the RITVO is the one I use for autism, the MOC I still continue to use, and the BSL-23 is a relatively new one for confirming symptoms of BPD, and the CTQ is, again, not one I use all the time. But I've found that sometimes when you're trying to connect with somebody who may have had an experience of trauma, that asking somebody to talk about it is very, very challenging, or you can be going backwards. But that offering somebody the opportunity to just circle a box or to write something down can be a less confronting way of starting to identify that this person sees that trauma is in their background, even if they're not necessarily ready to talk about it. My hope for the future is that we are at the beginning of a new age of using screening measures, but also biomarkers as ways of thinking more broadly, and also using diagnostic categories more accurately across the board and starting to pull apart the threads of all these different things that we've been talking about today. So thanks for your attention.
Thank you, Lukas, for that brilliant presentation, trying to cover the difficult topic of neurodiversity, trauma, and personality disorders, and the complex interplay of all of that. There are a couple of questions. The first question is, can you elaborate your thoughts about the overlap and the differential diagnosis of borderline personality disorder and autism in women?
In women. So it gets, there's been a number of situations I've been in where there's quite a lot of discussion about thinking about making a diagnosis of BPD in somebody that has an established diagnosis of autism. And for me, it certainly raised questions about ethical concerns in terms of the stigma that's been associated with BPD historically. But I think that one of the things that I've learned is that autistic people and neurodivergent people in general have the same needs to be connected and to have meaningful relationships, and that accessing that can sometimes be difficult for a neurodivergent person. That, certainly I've seen within families that you could have parents that have done everything and more for their child, but because of some of the particular challenges for autistic people, feeling loved and feeling connected can be difficult to access in the way that a parent might try to express it. And so when that happens, I think you can end up in a syndrome of BPD that's very much like a neurotypical person, in that this central need to attach, to feel loved, can be stymied. And so when that happens and somebody ends up in a situation where they are expressing that through self-injury or suicide, that is when I would say we should make a diagnosis of BPD as well, because I think it acknowledges the human side of everybody, including autistic people.
Thank you.
Answers the question. Yeah.
Thank you, Lucas. A couple of more questions. We'll see how we go with the time. The question is, what has been your false positive rates of ADHD in self-referred individuals with a diagnosis of borderline personality disorder?
Yeah.
The first part of the question. Second part of the question is that was it perceived as invalidating or re-traumatizing?
The ADHD.
When false positive diagnosis, self-referred.
Well, I think at the moment it's there's been so much media attention around ADHD. And we only just have our own Australian guidelines for the diagnosis and treatment of ADHD, that it's an area that we need to expand our knowledge in. And so at the moment, it's certainly I have quite a significant interest in trying to understand it better, because I think that there is quite a lot of overlap in the criteria for ADHD and BPD. And at this point, I don't think we really have a clear idea about who's going to potentially benefit from a diagnosis of ADHD and treatment, and whether or not and how they're going to relate to each other. And so at the moment, I don't know that I could give a really clear answer on that one, because I think that the science is still out, and we really need to look a lot more closely at people who are reporting high levels of ADHD symptoms, and how you actually define the difference between the two in a consistent way.
Thank you, Lucas. Does neurodiversity and borderline personality disorder, the co-occurrence, does it change your pharmacological approach?
Oh, certainly it's had a big influence for me. I think that we may end up with the same diagnoses at the end in terms of saying, okay, we've got autism and we've got BPD, but I think that particularly when you're talking to people seeking support and their families, if you can help them understand the road, say, okay, again, it's what I was saying before, is that it wasn't anything that anybody did. It's just really circumstance, and that helping to somebody think of that through from the lens of neurodivergency can be quite helpful. And I think that it can be very useful in terms of creating a whole picture of a person.
So thank you, Lucas. Thank you for answering all those questions. Thank you.
Thank you.
Okay, now we have the last presentation, but a very important presentation by Sarah Wallace, senior clinician, senior clinical psychologist at Spectrum. She is a trained DBT therapist, an excellent psychotherapist, and she works as a senior clinician at the Complex Care Service. And she has more than 10 years of experience in public, private, and non-governmental organization sectors. And she provides individual psychotherapy, secondary consultation, training, does family work, and presence in conferences. Over to you, Sarah. She's going to talk about treating complex PTSD using the dialectical behavior therapy model. Sarah.
Thanks very much, Sathya, and welcome everybody to the last talk of the day, I think, beside the closing address. Today I'm going to introduce you to a new trauma-focused exposure-based therapy called DBT-PTSD. It was developed over the past decade or more by Professor Martin Bohaus, who's an internationally recognised leader in the treatment of BPD and PTSD from the University of Heidelberg in Germany. Given the limitations of time, I'm not going to be able to go into a lot of detail about the treatment, Instead, I'll focus on some key aspects, and I'll share with you some of my experience in delivering the treatment as a clinician. And I'll also share some words from a client who I completed a version of DBT-PTSD with. So client A, who shall hereby be known as, has kindly given me permission to share her words with you here today. And finally, I'd like to provide another alert for emotionally difficult material, since I'll be talking about childhood sexual and physical abuse. DBT-PTSD is designed to meet the needs of people who have experienced childhood physical and sexual abuse and who have complex PTSD as well. The overriding aim is to help clients to live a meaningful life in accordance with their own values. It brings together a variety of third-wave behaviour therapies with elements of the following. Dialectical behaviour therapy. It brings with it the DBT framework, including the consultation team and diary cards, as well as similar principles and adapted mindfulness, emotion regulation and distress tolerance skills. As per the DBT framework, if life-interfering or therapy-interfering behaviours arise, these will be prioritised in sessions and a behavioural analysis will be completed. It also brings in elements of trauma-focused, exposure-based interventions, including Dr. Melanie Harned's DBT prolonged exposure and Dr. Edna Foer's prolonged exposure. DBT-PTSD is ultimately an exposure-based therapy. And we'll hear a bit more about exposure in this particular context in a few slides from now. It also includes elements of compassion-focused therapy. So the overall attitude of DBT-PTSD is one of compassion and a willingness to share and carry the traumatic experiences and suffering of our clients. The treatment also works to strengthen a client's compassion towards themselves and to others. And finally, it includes elements of acceptance and commitment therapy in helping clients with acceptance of their thoughts and feelings and in striving for a life that matches with their values. It is a phase-based treatment which allows for some flexibility. It consists of weekly individual therapy as well as a client-guided manual that includes worksheets and daily homework tasks. It can be conducted as a 3-month residential program or as a 45-session outpatient program over 6 to 12 months. And the manual has, it's not published yet, although a draft version is available to people who have completed the training. So as we heard about earlier today, there is an emerging evidence base. The first pilot study had a very small sample size and no control group. However, it did have a 79% remission rate for those who completed the treatment. And then the first randomised control trial was in an inpatient setting, and it had a control group of treatment as usual or wait list, which consisted of 6 months of their choice of therapy that was available at that clinic. DBT-PTSD demonstrated greater reductions in post-traumatic symptoms, and 39% of people who completed the treatment no longer met criteria for PTSD. The second RCT was in an outpatient setting, and it was compared to cognitive processing therapy. And DBT-PTSD demonstrated greater reductions in PTSD, and 58% of people who completed the treatment no longer met criteria for PTSD. And so overall, across these research projects, there were significant remission rates and also reductions in PTSD symptoms. So there was no worsening of PTSD symptoms either, or increase in crisis, self-harm or suicidal behaviours. And as Lois Choi-Kane mentioned this morning, a lot of previous PTSD research has excluded people who are demonstrating self-harm and suicidal behaviours, or who are using or misusing substances, or who have co-occurring eating disorders. And these were not excluded from these studies. The only exclusions in these studies were if someone had had a serious suicide attempt in the 2 months prior, or if they had ongoing contact with the perpetrator of their violence from childhood. So now I'm going to give you an overview of the treatment phases. And again, I'm not going to go into a heap of detail. I'm just going to give you a bit of an overview. So within these early treatment phases, commitment is developed through imagining and planning for a life post-complex PTSD. And this really helps to build hope and to help get the person through the toughest part of the treatment, which is the exposure usually. The DBT-PTSD trauma model helps us to understand the inner experience of someone's complex PTSD, particularly in the context of childhood sexual and physical abuse. And you'll also get to hear more about that in a couple of slides from now. In the middle phase of the treatment, there is a focus on skills, which can act to replace avoidance or escape strategies that someone has been relying on. And of course, there's the skills-assisted exposure, which you'll also hear more about today. The final stages orient the client towards acceptance that the past cannot be changed, as well as hope and planning for a life worth living despite their horrific experiences. And now I'm going to introduce you to client A. So client A was the very first client that I did a version of DBT-PTSD with. They had completed 12 months in our regular DBT program and were doing much better and engaging in life. However, were still suffering from PTSD symptoms such as flashbacks, nightmares, and self-concept issues related to traumatic events from the past. So we decided to offer an extension in which we would do trauma-focused therapy. So client A is a young female in her early 20s. She had experienced childhood sexual abuse over a number of years. In her adolescence, when she came to disclose the abuse to others, she wasn't initially believed. There was a period of estrangement from her family as well. And unfortunately, she experienced another sexual assault as a young adult. So on the right there is a worksheet called the Lifeline. And that's a worksheet we use in one of the early phases of treatment. And on the vertical axis on the left there is a rating from -100 to 0 to +100. And that's to rate the level of distress around significant life events, which are plotted on the horizontal axis. So that's age across on the horizontal axis there. So this is a really great way of getting to know the client as a clinician, and it's also a way of normalising the process of talking about traumatic events without avoiding them, essentially. And so sometimes this can be experienced by clients as triggering, and equally it can be experienced as validating, in that finally someone is recognising these experiences as traumatic and harmful, and so getting some of it out in the open can be experienced as a relief. And now I'll read a quote from client A. Before commencing this treatment, any slight exposure to things relating to my traumatic memories would shut me down. I became withdrawn and totally oblivious as to how or why. I didn't even know how much I was missing out on in life. And now I'm going to run you through the DBT-PTSD model for complex PTSD. So we create and draw up an individualised trauma model for each client based on this, so that they can develop a strong understanding of their own complex PTSD patterns. In my experience, it's been really powerful to pay attention to these symptoms and this experience that the person comes with, and especially personalised to them. Because often clients may not be aware to the extent with which their past traumas are related to these very difficult inner experiences that they're trying to escape and survive. The inner pie chart is called the trauma network, which represents what the client experienced at the time of the trauma, and of course goes on to form the trauma memory moving forwards. So it might include thoughts such as, I will not survive, emotions such as disgust, powerlessness or fear, as well as body sensations and imagery. In complex PTSD, we know that these experiences of interpersonal violence are often repetitive in nature, which consolidates the trauma network in the client's mind and body. This outer layer represents the self-concept that develops in response to these experiences of abuse. In complex PTSD, self-concept is very often heavily weighed down by self-blame, guilt, and shame. And as we know, self-concepts are core beliefs, so they're experienced as pure truth, they're not questioned, and they influence behaviour. And finally, in this model, there's recognition that traumatic invalidation further consolidates this self-concept. So traumatic invalidation is the unfortunately common experience of someone disclosing their abuse and of not being believed, perhaps of the abuse being minimised, of not being protected from further abuse, or of being treated like they are to blame, or of being rejected. Many survivors of childhood abuse report that the experience of traumatic invalidation is as hard to bear, if not harder, than the original abuse itself. And of course, this makes the task of ever again attempting to disclose the abuse as completely overwhelming. Sharing it with others can become deeply aversive and something to be avoided at all costs. Over time, this trauma model becomes a lens through which the person sees themselves, others, and the world. And as we know, in an attempt to switch off the trauma network, people with complex PTSD will often engage in avoidance or escape strategies, such as substance misuse, aggressive outbursts, or dissociation. The definition provided for dissociation by Dr. Martin Bohas is that it is a temporary disruption of perception. This disruption affects all parts of the sensory system: seeing, hearing, consciousness of one's body, and also the perception of oneself, time and space, and one's connection to the world. Dissociation blocks emotional learning that can otherwise occur during an exposure to a traumatic memory. Research shows that the level of activated dissociative features negatively correlates with treatment outcome. And we know that those with complex PTSD can be highly dissociative prone, and dissociation helps them to escape the trauma network when it gets activated. And as therapists, we need to help them find ways to dissociate less or develop more control there. So sensory input helps to remind us who we are and where we are perhaps in the current moment. So types and levels of sensory input can help us attenuate our level of awareness. If you've ever dived into freezing cold water, you'll know the feeling of being present. In contrast, sensory reduction or deprivation can help us into a meditative state. If you've ever been in a float tank or practiced yoga nidra, then you might know the feeling of being in that half awake and half asleep state, where you might lose track of time, where you are, maybe even who you are. We use sensory input in this therapy to utilise the power of our senses in helping a client to learn to have more control over their dissociation. So anti-dissociative skills are practiced in and out of sessions and can include standing on a wobble board, which requires a lot of attention and core strength to maintain balance. It could be the client or the clinician clapping their hands loudly. It could be the client having a sour lolly. It could be pressing on pain points, such as those under the collarbone or between the finger and the thumb. It could include holding an ice pack. We also might look, in using anti-dissociative skills, we also might look at finding opposite sensory experience for the ones that are bothering the client. So for instance, if the sensation of something sticky on the client's hands is within their trauma network, then we might try to find an opposite sensory experience for practice with, such as holding something that's dry and smooth. Now I'm going to share a little bit about what it was like leading up to exposure from my experience as the clinician. So approaching exposure in DBT-PTSD for the first time was a bit like going up on a roller coaster, very slowly. There's a growing sense of your stomach sinking and you don't quite know what's on the other side. but you do know whatever it is, it's going to come up very quickly. So anxiety and avoidance are apparently very common for both clients and clinicians in the lead up to exposure. In DBT-PTSD in Germany, the teams were given a time point by which they had to start exposure because there was so much avoidance going on that it was getting delayed too far into the treatment. So from my point of view, my fears included that I might re-traumatise client A by doing exposure, that the treatment might end badly or as a failure, and that she might end up back at square one, suicidal and in hospital. I'd first learnt about complex PTSD years before reading Judith Herman's book Trauma and Recovery, as well as other books by trauma experts who tend to caution against traditional exposure techniques in the context of childhood trauma. So this was in the background for me. Now I'll share some words from client A about her perspective about the lead up to exposure. I was in utter disbelief about the whole idea at first. It sounded absolutely crazy. There is always a fear of the unknown. When you spend so long avoiding something and hiding it because of the shame and guilt, it sounds crazy when someone is asking you to let them in and to uncover whatever it is you've been pushing down for so long. Now I'll walk you through what a typical exposure session can look like. So you'll see on the right there's a photo, that's Martin Bohas in a training video, and I'll give you a bit more detail in a moment. But firstly, in DBT-PTSD, the narrative of the trauma memory is not the most important factor. It provides the framework for the client to re-experience the emotional, the cognitive, and the sensory aspects of the memory. But it is not a fact-finding mission where the narrative altogether matters. As the clinician, you are there with them, guiding them through the sensations, the thoughts, the emotions. So you might ask open questions, like, what do you see? Or tell me what you hear. Or can you tell me more about that? So you don't reflect whilst you're in the exposure, it's a sensory experience. And language is present tense and matches with the age at which the trauma was experienced. And Dr. Martin Bohas would say that exposure is actually an opportunity to learn rather than habituate. So it's allowing emotional learning to occur for a person to recover from complex PTSD. The client needs to learn to re-experience the memory safely so that they can learn and develop control over the uncontrollable memories which have become a part of their inner and outer worlds. It's also dismantling the past from the present, so you're helping the client to move back and forth between the trauma memory and the present moment, and for the body and brain to register the difference between the two. So it's dismantling the trauma network from being chronically activated in the present moment. So as a way of assisting the client to become more adept at that moving back and forth, we might practice a skill called What's the Difference? And this skill involves identifying tangible things that are different between the trauma memory and the present moment. So you might ask a client, how tall were you at the time of the trauma? And then compare to how tall they are now. So in my experience, this skill can be a relief because you're paying attention to the trauma memory, but perhaps less threatening aspects of the trauma memory. So it helps to settle things when you're coming out of the exposure, and it can also sometimes just lighten the mood a bit because it's obviously exposure is pretty heavy. So we balance the trauma network and activation of the trauma network with strong sensory input. So this image on the right is Martin Bohas demonstrating how an exposure session can look. And activating the power of the sense of touch can be very powerful. So our hands are full of nerve endings, and if the client is agreeable and it's not triggering to their trauma network, Dr. Martin Bohas would recommend holding hands with the client while they stand on a wobble board. For client A, this would have been triggering of their trauma network, so we didn't use that method particularly or specifically. However, I have used it with another client, and it was quite an interesting experience. So it definitely made a difference to me as the clinician, and I felt like I was more there. from a sensory point of view. And afterwards we reflected on it, and it also felt from the client's point of view that I had been there as well. And so at first that had been quite upsetting for the client, because in the trauma memory, which was a memory of an extremely violent physical assault, they were actually calling out for someone to help them because they thought they were going to die. And so they later described that they wondered if I was there, why I didn't intervene to help them. But eventually they were able to kind of let go of that thought and take solace in the fact that someone was witnessing this. It was provided a sense of safety moving forwards for that memory. It's also important as a DBT-PTSD therapist to provide a discrepancy between the client's experience of disclosing details of a traumatic memory versus their expectation. A person who has experienced childhood abuse, and I think particularly sexual abuse, will often expect to be rejected and blamed when they disclose the abuse to others. So every exposure session where this does not happen, and not only does it not happen, but they are met with compassion and understanding instead, seems to be very important in their recovery. And finally, traumatic invalidation, which was discussed earlier, can become a target for exposure, since this can be experienced as difficult as the abuse itself. So I'll just, go back and forth here between my perspective and client A's perspective in getting started with exposure. So in the first couple of weeks of the first exposure, client A's flashbacks, nightmares, insomnia, and feelings of overwhelm all increased dramatically. So they needed a lot more in-between session support, and so we spent a lot more time on the phone. She was telling me she wasn't coping, and at times she was unable to bring herself to practice skills. And I think if there was a subtext, it was that she was really begging me to put her out of this misery and stop the treatment. And at the same time, she wasn't dissociating, she wasn't avoiding or escaping, so I took heart in that. There were sessions I came away feeling drained and as though maybe it was all too hard, maybe it's not worth it. So I took the opportunity then to, remind client A and myself that the pain is actually purposeful in this context. I allowed myself to feel hopeless in moments when it felt like it was falling apart. And we both needed reminding that the pain without avoidance is the purpose of this treatment. And so if you're in pain and not avoiding, then all is good. We weren't doing the exposure to decrease pain in the short term. We were doing it to decrease pain and suffering in the long term. And so it was an investment. I had to keep reminding us that emotions need to be processed. I also knew what we were walking towards and that it wouldn't come without pain. At one session during early exposure, she became rejecting of myself and the therapy. And that hadn't been a part of our dynamic so far, so it was quite unusual. We'd prepared for this using one of the DBT worksheets that consider what might come up in the therapeutic relationship based on their relationships with early caregivers. And so her perpetrator had been someone whose moods she had had to manage by hiding her own negative reactions to the abuse. And so there was no space for her own needs, emotions, and reactions. Not to mention that, therefore I validated her behaviour. We were challenging deeply held primal instinct to protect anyone from knowing this part of her. Not to mention that she must be allowed to have reactions within her relationships, and she couldn't keep self-censoring for the comfort of others. I definitely noticed some resistance within myself at different stages throughout the treatment, which I believe is understandable and expected. As discussed earlier, disconfirming expectations seemed like they were a key factor in this therapy with client A. Each exposure session where she wasn't rejected or blamed seemed like it was healing for her. My biggest concern in sharing these memories was the fear of judgment that I might experience. I have carried shame with me for so long regarding these memories. So the first glimpse of relief that I felt was when homework sessions started to become a little boring for client A. And they just reported that they were bored of listening to them, so they'd stopped. So we knew it was time to move on from there. When you grow up without a sense of security or safety, it feels scary at first until it doesn't. So exposure can feel like it's a high risk and then hopefully high reward experience. It's terrifying and at a certain point kind of exhilarating. So with client A, once we started to notice small signs of change and recovery, we both started to celebrate them. And so more generally, exposure can result in pretty rapid shifts in a person's self-concept and life outlook, and they need therapeutic support with this next stage also. So part of the therapist's role is to celebrate the joy that can be associated with this stage. So a major goal of client A at the start of the treatment had been to make a statement to police about their childhood sexual abuse. And they were able to do this in one setting, which they were really proud of. They also wanted to develop a career in an area that was their dream, and yeah, they got into the course and they're still studying and doing really well. Their relationships have improved, so they have a really good social network around them in terms of their study, and their family relationships as well have dramatically improved. They've developed skills in saying no to unwanted touch from others. So client A would freeze previously when it came to somebody touching them inappropriately or in a way that they weren't consenting to or wanting. And so towards the end of treatment, we had there was a situation coming up for her in which she knew that this would probably happen. And so we did lots of practice and skills and planning ahead to have a think about how to get her moving instead of shutting down and freezing in that situation. And she was able to do that, and you could just see her self-concept shifting in those moments. Her sleep improved in that she no longer didn't have nightmares as regularly, and her mindfulness in the present moment improved. I felt a sense of relief that there was one person on this earth that I didn't have to hide from, and that I could relieve myself of this massive burden with. I still feel uncomfortable and even a little bit confronted at times. However, my body doesn't jump into fight or flight. I know when to intervene and what I can do about it. It gave me the courage to face what has happened to me, and I was able to reach a place of acceptance. This therapy changed how I view myself, how I care for myself, and it gave me the courage I never thought I'd had in me. Now I'm going to run you through just, I think, 4 different outcome measures that we use with client A. So the first one is the SCID, which is a personality disorder interview, and the ones that are highlighted in blue are the criteria that she did meet criteria for those personality disorders, which was depressive personality disorder and borderline personality disorder. So at pre-treatment she met those ones in blue, and then post-treatment or at discharge, which was at 18 months, she no longer met that criteria. Depression was measured at 4 different time points. And so, yeah, there was the 6 months, 12 months and 18 months. And she went from moderate to normal levels of depression at discharge. Life satisfaction is an interesting one. So she started off, I think it was about 30-something, at the pre-treatment stage. Now you'll see the orange lines there are representative of normative data for Australians on their sense of well-being or life satisfaction. And so she went from well below to, at the 18-month time point, a bit above. So it ended up 92 or 4 or something. And then finally, we measured client A's PTSD post hoc. So we measured the past month score at 1 year post-discharge, as well as the worst month of PTSD that she had experienced. And this was estimated to be when she was about 18 years old. So at 18 years old on the left there, she got a score of 54, and she met the full criteria for PTSD. And then fast forward to the end of treatment, a number of years later, she had a score of 20, and she didn't quite meet the full criteria for a diagnosis of PTSD. And so she did still experience some symptoms of PTSD, however, she was doing really well functionally and in terms of managing them. So the orange line in the middle there is a mean or average for a clinical population. So just finally, I'm just going to quickly run through some of the limitations of the, data and method here. So obviously, client A she didn't receive a full version of DBT-PTSD. Further to that, it was the first time I'd conducted this therapy, so I'm not sure it would quite meet the manualised standard. And finally, the two of the measures, the SCID and the CAPS, essentially measured the treatment of DBT and DBT-PTSD. So they were just the pre and discharge time points. So there's no way to differentiate the impact of either. And I think that might be it. I think I had others and they've escaped me right now, so.
So thank you, Sarah. That was a very elegant presentation. I particularly enjoyed your slide where you shared your own perspectives, your own experiences and reflections, and the client's experiences and reflections while undergoing exposure. Thank you, well done. A couple of questions. The first question is, what are the pros and cons of selecting DBT-PTSD versus DBT prolonged exposure?
That's a tricky one. Well, I guess DBT-PTSD is designed as a standalone treatment. So I guess it depends where you receive the treatment, how it's set up. Whereas DBT prolonged exposure is generally it's a stage 2 treatment, prolonged exposure. So you would do stage 1 in DBT and then stage 2 you would do prolonged exposure. And even though that's how we did that with client A, it's not necessarily how you have to do DBT-PTSD. So it is designed so that it can be completed on its own.
Thank you. A question from me. You've been working at Spectrum for quite some years now, and you work with people who have histories of complex traumatization in the context of a general DBT treatment. Yeah. And now you're also doing DBT-PTSD. Do you feel your own satisfaction as a clinician is much better with DBT-PTSD, especially for people with histories of complex traumatization? And would you also comment about the person who is getting the exposure treatment? How do they perceive? What's your take? Yeah, I'm looking for your personal take on it.
It's I guess they're big questions. I think it can sometimes be a better fit for people, absolutely. And I think in client A's case, it was a better fit. And they had wanted trauma treatment from the outset. And I think that was really the main motivation for them to be there. I think it can feel more accurate in terms of working with complex PTSD than regular DBT. I think DBT is very helpful, and as we've talked about, other presenters today has talked about in terms of stabilisation, there's a lot of skills there that are really needed for people, before attempting trauma-focused work. However, I think complex PTSD just has a very accurate understanding of childhood abuse and how that can manifest later.
Thank you.
Yeah.
I think we have run out of time for questions. So thank you, Sarah. So before you go,
thanks very much.
Thank you. We come to the end of the day, and I'll request my colleague, Cathryn Pilcher, to give her closing remarks. Before you close, Cathryn, thank you for your contributions as well. Thank you.
Well, what a journey we've been on today. So thank you first to everyone that's attended today. And for all the questions that you brought through to make it such an engaging day and more of a conversation about things than just the presentations alone. Some of the big take-home messages for me, because I can't leave without a take-home message. There was something that Lois said on her last slide that really stood out for me in that it's not about the label. The label is not the problem. How we talk about it and how we work together towards the solutions needs to be the focus. And there was so much, but something that Loyola shared in terms of having positively, contingently connected conversations, we can work it out together, we can grow together, and we grow in that connectedness. There was a really beautiful theme that came through today about the connectedness, the relationship, and working together. And I know that that's what I'll be taking away today. All right, so there's a few thank yous before we let you all go. Firstly, I'd like to say thank you to all of our brilliant speakers today, to Lois Choi-Kane, Joe Beatson, Nitin Darwankar, Loyola McLean, Sathya Rao, Lukas, Cheney and Sarah Wallace. They've brought their expertise, they've brought their selves to the conversation, and it's been quite amazing. Also like to thank our lived experience panel, to Jacinta, Chloe, Rita and Trisha, who their harrowing stories just really brought to light the importance of the work that we do and doing it together. I'd also like to say thank you to all of our helpers. There was a lot of people behind the scenes, so thank you to everyone up there. But I want to say a special thank you to our workforce development team, and we do have a small gift for all of you. So if I can ask Jimmy, Eve and Liv to come forward and receive a small token of our appreciation. They have worked tirelessly for weeks on end to get this running, so thank you so much. Thank you all. We'd also like to say thank you to all the staff at the Convention Centre. Thank you for guiding us through all the technical things for the day. Really helpful. And this can just mention for a minute. Lastly, but absolutely not least, we really would like you to take a moment to give us some feedback. The feedback from every workshop and conference that we do helps us to focus on what we need to bring in the following year and to continually make this experience beneficial to all who attend. So if you could scan the QR code and fill that out before you leave, that would be amazing. But thank you again, everyone, and we hope you have a wonderful week.